picture is this, to try to kind of emphasize, okay, we talked about a whole bunch of stuff, but here are the big concepts. Okay, cool. So when we talk about a ligand or a drug fitting a receptor, obviously lots of things, different drugs, age, genetic mutations, disorders, what have you. Okay, so here we go. The two types of receptors. Yes, sir.
Gabapentin is a coincidence for its name, or does that have to do with the GABA?
Not quite. Gabapentin has some interesting ways that it works, and we'll actually probably talk a little bit more about that in the when we get into our neurology. Good question, great question. But yeah, gabapentin, it does have some action because you know it is an anti-seizure, but it has some really complex, weird things as well. But yeah, great question, huh? You guys are just putting things together left and right. Yeah, it's awesome. Okay, so like I said, we have these two different types of receptors. You have your ligand-gated ion channels or your ionotropic. An ionotropic receptor is a ligand-gated ion channel like the GABA we talked about, like benzos and GABA, like sodium channels, potassium channels. A lot of your cardiac drugs work by inhibiting ion channels. Okay, they inhibit ionotropic receptors. And you have your metabotropic, like the G protein coupled receptor we talked about the beta-2 receptor, albuterol. Okay, so you have ionotropic and metabotropic. These are your major receptor types that our drugs are going to work on.
Are all beta-2 going to have the G protein?
Yes. Yeah, all your beta-2. Yeah, all your beta-2s are G protein coupled. Some of your alphas and betas are not, though. And we'll talk about them in a little more detail when we get into to those particular classes of drugs. But yeah, your beta-2s are pretty much ligand-gated, or not ligand-gated, but G protein coupled. Yeah, receptors. Okay. So racemic mixtures, we actually talked about this in some detail in the chemistry. You guys remember the D and the L form of a molecule, the stereoisomers or the enantiomers. And guess what? We have racemic mixtures of drugs. Okay. For example, epinephrine comes in a racemic mixture. That means racemic means 50% right-handed form and 50% left-handed form, right? I have a 1-to-1 mixture.
We only use the left.
What's that?
We only use the left-handed form in
No,
our body.
a protein, the left-handed form of proteins we only use in our body. We only use the right-handed form of carbohydrates. But yeah, with epinephrine though, like if I give racemic, you guys have heard of racemic epinephrine, right? You nebulize it and you give it to primarily like kids with croup and things like that. Racemic epinephrine is a mixture of 1-to-1 right and left-handed molecules. Okay. Now some medications are not racemic. You can concentrate the left or right-handed form because the left and right-handed forms can have slightly different pharmacological characteristics. And we talked about that when it came to albuterol. And albuterol is racemic. It's a mixture, it's a 1-to-1 mixture of right and left-handed albuterol molecules. And when I just pull out the right-handed albuterol molecules and concentrate them, that's a medication called Zopanex, right? Or levalbuterol. Sir?
Isomers. I don't think there was anything about isomers on the past slide. We're talking about isomers here, and I'm a little lost as to what an isomer is.
An isomer?
Isomer.
Yeah, remember we talked about that in pathophys? An isomer is a molecule that has the same components, but they're bonded a little differently. And remember I said the mirror image? Remember I gave you the right and left-handed? We talked about that in pathophys. And I said you can have a right-handed molecule like this, and then you can have, what's the mirror image of a right-handed molecule?
Oh, okay.
The left-handed. Now, they kind of look the same, right? But are they exactly the same?
No.
Do they have 5 fingers, though? They have the same 5 fingers, but can I put them on top of one another? Like this. Can I superimpose?
No.
No. Even though they have the same components, right? 5 fingers, those 5 fingers are configured a little differently. So I have my right-handed configuration and my left-handed configuration. Does that make
Yeah,
sense?
now I'm on track.
Okay, cool. So these are chemical mirror images is what they are. Okay, these particular isomers. Okay. Okay, agonists versus antagonists. We talked about what an agonist is and what an antagonist is. All right, potency. Something's potent. That's how much of the drug do you need to give for desired effect. And we know that fentanyl is more or less potent than morphine. It's more potent, right? Morphine, you give 10 milligrams of morphine, you get a certain effect. You only need to give 100 micrograms of fentanyl, 100 micrograms, to get the same effect. That's about how the conversion goes. So certainly fentanyl is much more potent. Okay, so when we're looking at drugs, one of the first things we try to do is we try to develop what's known as a dose-response curve. We try to find out what dose is equivalent to what response. Now, is this going to be the same in every person or every animal? No, it's going to vary pretty significantly, so it's kind of an average. It's kind of on the average, this is what we find. And then efficacy just refers to the maximum effect that a drug can produce. Okay, how good is it at producing the effect that we want, the desired effect? What is its efficacy? Okay, now, when we administer drugs, okay, your receptors can adapt to the presence of drugs over a long period of time. And that adaptation is known as tolerance. Okay. And what does that mean? Well, it means that those receptors go through what's known as downregulation. A receptor will downregulate and it will become tolerant to the presence of that drug. So what often do you end up having to do? You have to increase the amount of drug you give, right? Because your receptors are becoming tolerant. They are going through what is known as downregulation. Okay, they change, you have some changes, you may even lose, you may actually get rid of receptors. They'll adapt and they will degrade and downregulate in response to chronic elevation in a certain type of drug. We see this with our opioids, right? People that take opioids for chronic periods of time, what happens? Their opioid receptors downregulate in response to the high levels of the opioids, and you have to give higher doses to get that same effect. Does that make sense? You guys have probably seen this. You probably have patients that you see a lot that deal with these issues where they're not, for a variety of reasons, either they having to take larger and larger doses of medications to get their pain under control. Okay? We can see this tolerance occur with other medications as well, not just the opioids, but the opioids are a good example because we're all familiar with them. All right. So, desensitization and drug dependence. So, desensitized, okay? These receptors are not stimulated as much as they normally would be. Okay, they go through, we talked about downregulation. Okay. Another example might be with your beta-2 receptors. Sometimes people that take beta-2 agonists, particularly like long-acting bronchodilators, so COPD patients, asthma patients, they may require higher doses of bronchodilators to get the same effect because their beta-2 receptors will downregulate in response. So it's not just something that happens to opioids. It can happen to lots of other receptors and lots of other drugs. Okay? Eventually you can develop dependence. Okay? And dependence can lead to addiction. And the dependence can be either psychological or physiological. Okay? Physiological dependence is a receptor level issue. Okay? It stems from the fact that your receptors have gotten used to having a certain level of drug in your body, and when you stop taking that drug, those receptors, there are physiological signals that happen in response to that, and you can have some really bad things happen to you. Yes, sir?
So what's the biggest difference then between tolerance and desensitization? Is that just like
Desensitization is what leads to the tolerance. So you have this, they become desensitized, they downregulate, and you have to give higher and higher doses, and eventually you develop tolerance, and then tolerance eventually leads to dependence, and dependence leads to addiction. So it's kind of like a, I'm not sure what the word I want to use, but it's kind of a long process. There's not just like, okay, now I'm dependent, and then all of a sudden I step over here and I'm addicted. It's kind of this gradual cascade of things. Excuse me. So, you have this psychological and physiological dependence. In some medications, you can develop both psychological and physiological dependence. For example, let's take cocaine. Cocaine does not have profound physical dependence. Okay, if you quit taking cocaine, are you going to die?
No.
Now, will you withdraw? You will go through primarily a psychological withdrawal. You will be uncomfortable, you will crave, right? Just like nicotine, right? If you stop smoking, you crave smoking, right? You crave a cigarette, you want to stop. You want to smoke, right? Mm-hmm. Or you've seen people like that, right? Is that harmful though? Do people die from quitting smoking?
They feel like it.
They don't. They feel uncomfortable, but they don't typically die, right? They're crabby, they're uncomfortable, they have psychological, and there is physiological dependence there, but there's a big psychological component with the dopamine pathways in your brain. But if you go to someone who drinks a quart of whiskey a day, and they stop taking their whiskey, they will die, won't they? They will develop delirium tremens, right? They'll have seizures, they'll hallucinate, they'll have hemodynamic instability, and they will freaking die from withdrawal. That is a profound physiological dependence. That goes beyond reward pleasure pathways in the brain, and that is a very profound receptor physiological dependence. Is everyone okay with that? That you can have yeah.
On that alcohol
Mm-hmm.
one, how long do those take to set in?
They can happen pretty quick, actually.
Within an hour?
Within a couple hours, yeah. Yeah, they can happen pretty darn quick, yeah. Yeah, they can happen quick. And typically when people withdraw from chronic alcohol abuse, they need to be hospitalized. This is not generally something that people do at home. They need to be hospitalized because we need to give them things like Ativan to prevent seizures and to stabilize them. What's that?
They're in bad shape.
Yeah, they could be in just terribly. It's one of the few drugs that's truly life-threatening to withdraw from. What's that? Of alcohol? Not really, no. Huh? They give them gives them some little doses. They might very well. Yeah. Yeah.
And when they had alcoholics that were withdrawing, they would give them alcohol, but they also had to have a sitter at the same time.
Right.
They would basically wean them off of it.
They might. Yeah, some people might wean. Yeah. A lot of times what happens is you run into people that either run out of money or whatever, and they just can't access the alcohol, and then what happens? They go into acute withdrawal because they just simply can't access it. Or they turn to other substances like mouthwash and methanol and other toxic alcohols. Cool. All right. Okay. Moving on. So, when we talk about pharmacodynamics, this is not really a pharmacodynamic concept. This is actually technically pharmacokinetics. But I'm going to talk about it here because this is a good segue into talking about enzymes in a little more detail. So, we have two general ways that we look at the elimination of drugs. Okay, these are what we call elimination kinetics. I have something known as zero-order kinetics. Zero-order elimination kinetics. Zero order elimination kinetics is a constant rate of elimination. Okay, a constant rate of elimination. So if I were to plot, if I were to graph the elimination of a drug with zero order kinetics, it might look something like this. Here's time on the x-axis, and here's the concentration of the drug on the y-axis. And I start here at some high concentration, and then as I metabolize and eliminate that, I have a decrease in concentration over time. Is everybody cool with that? And do you see how this makes a straight line? And the slope of this line, okay, the slope of this line, that's the rise divided by run, the rise over the run, the slope is constant. It doesn't change, right? Does that make sense? A straight line, it's an unchanging slope. Is everybody cool with that? So it doesn't matter how high the concentration of drug is in the body, it is a constant elimination. Is everybody cool with that? Does that make sense? Mm-hmm. That's not how most drugs are eliminated. Okay, there are a few exceptions, but most drugs are eliminated through what are known as first order elimination kinetics. Okay? First order elimination kinetics are very different. They are, let me erase this stuff here and I'll draw you another picture. First order elimination kinetics, get rid of this here, are exponential. So if I were to graph first order elimination kinetics, I would see something that looks like this. All right? What do you notice about this?
It's definitely not a straight line.
Not a straight line, it's curved, right? So the rate of elimination is changing, right? And what happens is the higher the concentration, the faster it's eliminated. The slope is really high here, right? Does that make sense? And then as the concentration decreases, the elimination decreases. The rate of elimination gets lower as my concentration gets lower. So the higher the concentration, the faster I eliminate that drug. That's what's called first order elimination kinetics. And the reason that most drugs are eliminated this way is the following. Imagine that I have 5 enzymes. Okay, you guys cool with that? And let's say that these enzymes deactivate a drug and allow us to eliminate. You guys cool with that? Everybody's cool with that? Now let's just say that my concentration of the drug is really low. I just have one part of the drug. What are the chances of just this one drug by itself hitting one of these enzymes?
Low.
It's kind of low, isn't it? Because it's just one drug and it's just randomly floating around the body and it has to randomly run into an enzyme. Does that make sense? So down here where the concentration is low, the elimination rate is very low because the chance of those two coming together is very minimal. Does that make sense? Mm-hmm. But let's say I now have an increased concentration. What are the chances of this increased concentration, one of these hitting an enzyme and getting eliminated? Much higher, right? Does that make sense? So the higher the concentration, the higher the chances are that they'll hit an enzyme and the faster elimination. Until something happens. Until my concentration gets so high that every enzyme is busy with the drug. And once my enzymes become busy, they're all busy, we call that saturation. And once your enzymes become saturated, what do you think happens to your elimination kinetics? It goes from first order to zero order elimination. How cool is that, huh? Craziness. Some drugs, that saturation happens at very low concentrations, and those are drugs that we say are zero order elimination. In some drugs, that happens at very high concentrations. One of the major drugs where saturation occurs at very low concentrations is alcohol, ethanol. Ethanol is not eliminated by first order. It's a constant rate of elimination, right?
I guess I'm a little bit confused. So you eliminate a number of those, and then you're back down to a couple of them left, that chances of them hitting those enzymes is
A lot
very
lower.
high. So then you go back from 0 to first order after that?
Yeah, basically with here, when your concentration of drug is low, so let's do this. Your elimination rate is going to be low.
Correct.
And then as I start adding drug and the concentration goes up, the chances of those drugs hitting enzymes increases until I get to a really high concentration, and maybe way up here I get saturation,
Okay.
and then this is constant elimination until the concentration goes back down low enough,
And then you switch back over to first order.
and then I go into first order. Yeah.
Okay.
So saturation is 0 order?
Saturation kinetics are 0 order, and then first order is prior to saturation. Does that make sense? So one of the major drugs that exhibits 0 order kinetics at very low concentrations is ethanol or alcohol. Does not take a whole lot of ethanol, and then you go into 0 order. And you have a constant rate of elimination. So, with that said, when dealing with first order elimination kinetics, there is a concept known as a half-life. But half-life only applies to first order. Okay? So if you're talking about alcohol, eliminating alcohol, you're not talking about half-life. There is no half-life there. So half-life occurs when you have this exponential curve here, okay, a changing curve. So let's talk about the half-life. Half-life is often symbolized as T1 half, okay? So let's say that I have a drug that has a half-life of 5 minutes. You guys cool with that? 5-minute half-life. And let's say that the concentration, or let's say that I have given 100 milligrams of that drug IV, okay? So I have 100% bioavailability. How much of that drug is going to be in the body after 5 minutes?
50 milligrams.
50 milligrams, right? Okay, so that's one half-life, 1 T1 half. How much of that drug is going to remain in the body after 10 minutes?
25 milligrams.
25 or 0?
0.
Should be 0.
So let's look at this. So let's say that this curve, this is a curve here, right? So let's say that this is a curve, and the concentration here, let's say I've given my 100 milligrams way up here, all right? And then 5 minutes has gone by, and I'm down here at 50 milligrams, okay? And then another 5 minutes goes by. Do I still have some drug in the body?
Yes.
Yes. So here, when the concentration is really high, I had a lot eliminated, right, after one half-life? But here, not so much. There you go. A half-life is a half of a half of a half of a half. So after 2 half-lives, I would have how many milligrams? 25 milligrams. And then after 3 half-lives, I would have, so 15 minutes, I'd have 12.5 milligrams. And then after 4 half-lives, 6.25 milligrams. 5 half-lives, 3.13 milligrams. 1.5, and so on and so forth. Yes, sir?
So with that theory, if you've ever been administered a drug, it never ever leaves your system.
Yeah, by use, you could, in a sense, this will, what's called asymptote.
Yeah.
It'll approach 0, but may never ever actually reach 0. And if you think about that, is that consistent with this picture up here? Could you have one molecule or a couple molecules of drug floating around in your body that you took 5 years ago and it just, by random chance, just never found an enzyme to be?
That's so interesting.
Yeah. So it will approach zero. And you see the area underneath this curve here? This area is the amount that you've actually gotten rid of. So you see how it's large here? Where you had that large jump in that first half-life? And then it gets smaller in the second, third, fourth, fifth. And it just asymptotes or approaches zero, but never ever quite reaches zero. Now, we generally say in pharmacology, we say after about 5 half-lives, it's like you're at zero. I mean, it's so low, you might as well be at zero. But there you go. Good questions. All right.
So 5 half-lives is the magic number.
Generally, yeah. Generally about 5 half-lives. Okay. Now, some medications have a really long half-life, like amiodarone. Amiodarone has a half-life of about, does anyone know?
5 years.
Not quite 5 years. 60 days.
That's a long time.
So if you give somebody an injection of amiodarone, you got 60 days. So 5 half-lives is going to be a long time. But something like adenosine has a half-life of about 6 seconds, right? So 5 half-lives there is pretty short. Yes, sir?
How are you distinguishing between the half-life of the medication itself and the half-life of the metabolization of the medication? As far as your body is going to get rid of it at a certain rate, but the medication itself just sitting there.
Right, right. So when we talk about the half-life, we're talking about actually getting rid of it, but that may not be as long how long the medication is active.
Okay.
Does that make sense?
Right.
So you're right, half-life doesn't necessarily mean the medication is active, it just means that I'm getting rid of it, I'm actually eliminating. So you could give something that had a long half-life, but its pharmacological action may not necessarily be as long.
So where you're saying amiodarone has a 60-day half-life in our body?
Yes.
So it takes us 60 days to
By one. Yeah.
So why does amiodarone have a maintenance dose? It seems like it's a high dose, and if it stays in there, why give it a maintenance dose? If you gave it that bolus,
Right.
it's going to stay in there for 6
Because remember,
days.
when you give that bolus, some of that amiodarone, I don't know, what's the volume of distribution? Where does it go? Some of it's going to get bound to plasma protein, some of it's going to go into your fat. And so you maintain that infusion. So what's going to happen is you're going to give the amiodarone, right?
Let it go wherever it wants to
Yeah.
go.
So right here, let's graph this out. Let's say this is amiodarone. And let's graph a picture of the body. Wish I had more blackboard. Okay. So here's the human body. Okay, there's a plasma, there's a protein, and there's my fat compartment. Okay? So I'm going to give my amiodarone. I give it IV push. So initially, what's going to happen when I give the amiodarone IV push?
It's going to go somewhere.
It's going to go, whoop, the plasma concentration go way up, right? And then it's going to move out, and it's going to distribute into these other compartments, right? And then as it distributes into the other compartments, what's going to happen to the concentration in the blood? Oh, it's going to go down. So then I'm going to start my maintenance infusion, and I'm going to prevent it from going down, and I'm going to keep it right there at that steady state. And then once I've got them at that steady state, in about a day, I stop the maintenance infusion and put them on oral tablets, right?
So your bolus is basically just to saturate the other compartment?
Yes. Bolus is the boom, give it, and you know that some of it's going to go in the lipid compartment, and some of it's you're going to lose some of it to protein binding, and then you're going to start your infusion as it starts moving off into those other compartments.
So Chris, is that one of the reasons why it takes so long to be eliminated? Is that you're saturating compartments that aren't necessarily going to be used to get the effect that you want out of amiodarone?
Yeah, and other drugs like lidocaine, but lidocaine of course has it's metabolized a lot faster than amiodarone. Yeah. All right, you guys good with that?
Yes.
So? All right, cool. Great questions. I rarely ask these kinds of questions, so you guys are definitely thinking. Okay, so here's just a much better picture of zero-order elimination, where it's just a constant rate, and then you have your first-order elimination there. I actually had to put these in kind of, to make my own graphics. We know that that wouldn't actually go down to zero, that it would just kind of asymptote towards zero. Okay, so half-life, we know that if you have liver or kidney problems, that's going to affect your half-life, isn't it? It may be longer in certain patients. All right. Talk about maintenance and loading. We'll talk a little bit about the pharmacology. Almost done with the PowerPoint. Hooray! There is another concept called the therapeutic index, or the TI. Just more terminology to throw at you guys, I'm sorry. The therapeutic index is how safe a drug is. Okay? And the therapeutic index is a ratio between the minimum effective dose and the maximum tolerated dose. So, if I were to draw that for you guys, I'll just go back here. I'll kind of neglect you guys a little bit. So let's say that I have drug A here and drug B. And I'm going to graph drug A and I'm going to graph drug B. All right? And let's say that drug A has a minimum effective dose right here. Okay? And a maximum tolerated dose right here. Okay? Everybody cool with that? So my minimum effective dose is down here, and my maximum tolerated dose is here. We know that if I go above the maximum tolerated dose, I have toxicity, right? I have toxicity occur. So now let's look at drug B. Let's say that drug B has the same minimum effective dose, but the maximum tolerated dose is down here. What does that tell you? It's more potent, and the risk of toxicity is higher or lower in drug B?
Higher.
This is higher, so this is more toxic, right? A therapeutic index, and the therapeutic index is basically this distance here. Okay? And do you see how the distance is much smaller over here? So this has what we call a narrow therapeutic index. So the risk for toxicity is much higher in drugs that have a narrow therapeutic index. For example, you could give somebody a lot of albuterol, okay, and they might do okay, but if you give them, let's say, another bronchodilator like theophylline, the therapeutic index for theophylline is very narrow, and that risk for toxicity is much higher. Does that kind of make sense? That's all the therapeutic index is.
Does DID fall under B, having a very narrow therapeutic?
Digoxin, yes. Yes, it can have a very narrow, yeah. And then if you have electrolyte imbalance, that can make DIG even more narrow. Yeah, particularly potassium. You have potassium imbalances. Cool. So drugs with a low therapeutic index are going to be more toxic. You're going to be much more concerned about your dosage with those particular patients. Okay, orders real quick. So we talk about an order. Some of the things you're going to want on orders. You're going to want the name of the drug, okay, the dose, how it's to be given, how often, and the physician's signature. Now, do you guys have orders to give drugs out in the field? Is that how it works for you guys? Ah, damn it. Yeah, you guys have protocols, right? And your protocol, yeah, basically a standing order, yeah. So you certainly do have orders. And last but not least, I want to make sure you guys are good on your rights of medication administration, and I'm sure this is something that you've talked about as EMT intermediates and basics. So the rights, okay? The right medication needs to be given at the right time. You need to give the right dose, the right route, the right concentration to the right patient, and finally, you need to have the right documentation. Is everybody okay with the rights of medication administration? Really easy to mess this up, particularly in EMS. For whatever reason, you guys can have a tendency to develop what's called muscle memory, where you get used to doing the same thing time and time again. And this actually happened a couple of years ago in clinicals. I was actually at the hospital with a group of, this is during the first accelerated medic course. And one of the students there, we had an order for diazepam, and we reviewed it. Okay, you know, you're going to give 5 milligrams of diazepam. You good with that? All right, go ahead and draw it up and give it. Student comes to me, he says, I just gave the whole thing. What? He's like, I just gave all 10 milligrams. Why'd you do that? You're only supposed to give 5. He's like, I don't know, I just gave the whole thing. I'm just so used to drawing the whole thing up and giving it. And he made a meta error. Really easy to do. A year ago, about a year and a half ago, in the second accelerated medic course, we actually had a situation where one of the students was so anxious, for whatever reason, he could not stop himself. And it was the funniest thing. He was shaking. I think he was going to give dextrose, half an amp. He was going to give half an amp of dextrose, 25 milliliters, right, 12.5 grams. And he started pushing it, and he got to the 12.5, and he's like, I know I'm supposed to stop, but I can't stop myself, and he gave the whole thing. And it was just the weirdest thing. He's like, I know I'm supposed to stop, but he just kept on giving the whole thing. It was just bizarre. Human beings can do some really bizarre things, particularly when you train, and you guys are probably used to just pulling the epinephrine and screwing it in, and boom, you hit it, and you're done, right? And you just do that, and you become this unthinking machine that just, right? And you develop that habit, that muscle memory, and then you can bring that into the clinical setting. Luckily, students tend to be better than people who are not students. Generally, students are terrified of hurting people. And I don't know, have you ever been in the hospital where you've worked around people or patients are like, I don't want a student taking care of me, blah! And you know, I just, sometimes I even try to talk to them, I try to say, hey, you understand that the students are terrified of hurting you. They don't want to hurt you because they don't want to get kicked out of clinicals, and they don't want to pay back whatever tens of thousands of dollars of money that they would owe if they got kicked out. They really don't want to hurt you. That cranky old nurse that was in nursing school 15 years ago is having a bad, busy day. She's not as interested in your well-being is perhaps not first and foremost on her or his mind. And so really, we see that students are, at least at this level, I mean, I can't say when it comes to, you know, physicians and that, but, you know, when it comes to like paramedic students, they generally are very conscientious. They don't want to hurt people. They want to do things right. And you've probably seen this. What happens when people get out of school? You get more and more complacent the longer you've been out of school. And there's, again, there are some large studies involving paramedics. And the longer that paramedics have been out of school, the worse that they do on their ability to accurately calculate correct doses of medications to give. So there is some efficacy to that. So that's why I kind of wanted to throw that in there. I actually had a med error back in 2007, and it was because of complacency. I was traveling at the time. I was a travel nurse in Nevada. I was working in Nevada. And what I do is I had what's called a 6 on, 8 off. So I'd work 6 straight 12-hour shifts, and then I'd fly back into El Paso, and on my I'd have 8 days off. So I'd work 6 days on, have 8 days off. On my 8 days off, I was in El Paso and Las Cruces flying on the helicopter. And I'd fly for 8 days, and then I went back to Nevada, and I worked for 6 days, and I'd come back. You know, so I was basically just a machine, right? It was just a machine crunching orders, right, doing stuff. And I received an order to give promethazine, 25 milligrams of promethazine, Phenergan. Cool, right? Go in, draw it up, dilute it, give it over 2-3 minutes, boot the patient out, we're fine, right? Then they're doing QA on the charts, and what did they pop up? They're like, hey, you charted that you gave this promethazine slow IV push diluted, and the order says 25 milligrams IM. Yeah. I neglected to give the right route, and it's because I was a machine. I was a complacent machine. I read 25 milligrams. I'm used to giving it IV, and that's what I did. So simple things like that can get you into trouble. Okay, we talked about these already in intro, but there's just a table as far as proper abbreviations. Pregnancy category, we'll go over this real quick, make sure everybody's on the same page. So pregnancy category is A, B, C, D, and X. What is A? What is a pregnancy category A? Yeah, that's the safest, right? There are very few drugs that are category A. And basically what that is are adequate and well-controlled human studies that have failed to demonstrate any harm to the fetus. And is there a word that means harm to the fetus? It's a word that they love to throw in books and tests and things like that. Tetragenic. Tetragenic. Yeah, tetragenic means harmful to the fetus.
Teratogenic
Huh? Teratogenic. I say tetragenic. You could probably say it either way. Teratogenic is probably maybe a bit more proper.
How do you spell it?
I was just trying to spell it.
Oh,
That's what we're trying to do.
yeah. Teratogenic. Teratogenic. I call it tetragenic. Obviously, it's not totally proper. Yeah, teratogenic. You guys good there?
Mm-hmm.
Harmful to the fetus. Okay. So, very few drugs fall into that. Category B is animal studies have failed to demonstrate any risk. And there's a lack of evidence that shows it's harmful in pregnant women. There aren't big studies, big randomized controlled trials, but there's really good animal evidence and nothing has happened in animals, and there's no other reported evidence showing adverse fetal effects. So that's something that's pretty safe, okay? A is really safe because we have the adequate, well-controlled information in humans. But B is we have that evidence in animals, not so much humans. C is where we start having some issues. If something falls into category C, animal studies show adverse effects. Okay, so there have been some teratogenic effects in animal studies. Okay, but we are uncertain when it comes to human studies. Okay, so when you have something that's a category C, this is a risk-benefit. You have to weigh risks and benefits. Category D, okay, there is some evidence of human fetal risk. There is some evidence, okay, in small studies. Okay, so guess what? Risk versus benefit. And then category X is, we know that these are demonstrably teratogenic. Okay, these are grossly teratogenic, and we know we have robust evidence that shows that these are absolutely harmful and that there are no situations where the benefits would outweigh the risks of giving these medications. So something is category X, it is absolutely contraindicated in pregnant patients. All of the other categories, okay, B, C, and D are risk versus benefit analysis, and then A is perfectly safe. Good luck finding an A in any of the medications that we administer.
These also for like vaccines.
What's that?
This is also for
Yes.
vaccines?
Yes.
So like with the West now, they didn't really test it for,
Right.
so I mean, where exactly did it fall in the
I don't know where West Nile, if they have good animal studies or not. I don't know. I would assume that West Nile is probably going to be C or D. I assume. I don't know though. Yeah. But yeah, vaccines. Yeah, any therapeutic agent. Yeah, will have a associated pregnancy category. Most of the drugs that we administer fall in the C and D range there. Okay. Whew. Now moving on to the Controlled Substances Act. Okay, so this is the United States government. This is federal. This is not state. Some states have a different way of defining controlled substances, or what we call schedule substances. Is everybody okay there? So a Schedule I substance per federal mandate is a substance that has a high abuse potential and there are no accepted medical uses for that. Okay? This includes things like heroin, LSD, marijuana is on there, peyote, ecstasy, etc.
how is marijuana on there, but it's,
Oh.
they have medical marijuana?
Remember I told you,
Oh.
this is federal.
Okay.
Yeah, federal, yeah. I wanted to make sure because, for example, New Mexico has medical marijuana. So New Mexico does not consider marijuana Schedule 1, but the federal government still does, okay? So there, it's kind of a gray area that they're still trying to sort out right now, the federal versus states' rights. And obviously we have states like Colorado and now Washington that have legalized it. But what does that mean? Does that mean that you are completely free from prosecution? Possibly not, because it is still a Schedule 1 substance at the federal level. But for the most part, the federal government, it looks like it's been kind of staying out of that. Individual people that are using it in the states. But it is what it is. Your Schedule 2 are high abuse potential, may lead to severe dependency and addiction, but there are some accepted medical uses, but they're very limited. Okay, and these include things like cocaine and amphetamines. Believe it or not, cocaine is not a Schedule 1. It's a Schedule 2. Cocaine is sometimes used as a topical anesthetic, particularly in oral and nasal procedures. It can cause anesthesia, and it can cause vasoconstriction and control bleeding. So it does have some limited uses. Most of your really potent opioids, like hydromorphone, which is Dilaudid, methadone, meperidine, which is Demerol, fentanyl, which is Sublimaz, morphine, amphetamines, okay, fall into this Schedule 2. Schedule 3 agents are agents that have less abuse potential than 2, okay, and there is a moderate risk of physical, psychological dependence. And these include a lot of your common prescribed oral pain medicines like hydrocodone and acetaminophen mixtures, which is Vicodin. Yes, sir.
At the beginning of this month, Vicodin just got moved to last year.
Yeah, I know. I knew they were looking at moving it up. Yeah. Federal? Is that federal? Federal. There you go. Yeah. See, things change. Yeah. That doesn't surprise me. It really, most of your opioids are probably going to be in Schedule 2. Yeah. Tylenol with codeine, I believe, is still a Schedule 3, depending on the amount of codeine. Some of these others, like Stadol, you don't really see it used as much. And then your Schedule 4 have relatively low abuse potential, and these include a lot of your Zams, so your benzodiazepines, like Xanax, which is alprazolam, lorazepam, which is Ativan, okay, anti-seizure, anti-anxiety meds. And then you have the Schedule 5, really low abuse potential, and this is kind of like certain cough syrups that maybe have just a little bit of codeine in them. But again, you don't really see this used as much anymore. Sir?
While we're on the topic, the Vicodin up there, I'd always thought about this, but never did I think to ask anybody. We talked about the synergism and the potentiation earlier.
Yeah.
Why are those two paired together? What is the purpose of that?
For pain. Acetaminophen is Tylenol, right?
Yes.
Yeah.
But why do they mix the two together into one pill?
Just Tylenol has a little bit of pain relieving properties. Vicodin or hydrocodone has some pain relieving properties.
Different half-lives, maybe?
Huh?
Oh,
Well, they're different agents. They work in different areas, right?
So it's kind of like a blanket kind of.
Yeah, you might say. Tylenol works on different receptors, right? It does not work on opioid receptors. We think Tylenol works more on prostaglandins. But I think you pose a good question, because why don't we just see hydrocodone being given?
Is it for the abuse potential of hydrocodone?
It could be, but people abuse Vicodin, right? That's why Vicodin has been moved up. It's the hydrocodone. What we're seeing is people take a lot of Vicodin, end up having chronic liver failure because of all the Tylenol they're getting.
Which is why I wonder why they even bother. People are going to abuse pills no matter what, so why don't they just pull the Tylenol out and save some people's end organs?
Why? Yeah, why don't they? I don't know. I don't have a really good answer for you.
Okay.
Yeah, you know, sometimes I ask myself, why don't they just put all this in the vending machines, and then anybody who wants it can just get some for 50 cents and
call it a
it
day.
is what it is. But yeah, but that's more political, you know. That's more my politics, and I'm not here to push any sort of ideology on anybody. Our country, there are a lot of changes going on. We're asking lots of questions, and we're struggling. We're really struggling with drugs when it comes to drugs and how we deal with them and how we regulate them and what do we do with people. And, you know, there's more confusion and discussion when it comes to drugs now than ever before. And you know, really, you know, we had these issues like with when they started making some of these substances illegal, when they first started passing some of these acts, and certainly during Prohibition. But we've come back around. We're asking a lot of questions. We're coming up with, you know, against a lot of things. I know Ed had mentioned a law that they were considering in some places about marijuana and work. Apparently, there's some people that were, I think Colorado.
Oh yeah.
And they popped positive, right? A drug screen, and they lost their job. And so they're like, well, it's legal in Colorado. And I think what's being argued, again, I don't know all the details, so please double check me. But I think what's going on is, what the argument is like, well, yeah, it may be legal, but as an employer, I can still say what substances I want my employees to be putting in there. Just like, is alcohol legal to consume in the United States? Mm-hmm. Yes. But if you guys pop positive for alcohol at work, would you have a job tomorrow?
Yes, but if I pop positive for alcohol, it means I'm drunk.
Yeah.
If I pop positive for taking hydrocodone that I took on the weekend because I hurt my leg in the garden, that's not really the same thing, you know?
It's not. And we're trying to figure out, particularly with like marijuana and driving, we don't know. We just do not know. There's not a test that we can run like alcohol. Alcohol is a little odd because if you have somebody who drinks a lot of alcohol, they can have a really high blood alcohol level and still be functional. So there's so many questions that we're having a hard time answering at the end of the day. And I wish I had better answers for you guys, but I don't. Other than to say that, you know, there's going to be a lot of discussion, a lot of dialogue. All right, that's it for now. I just like to end. I don't know why I like this picture, but this is my kit that I had over in Afghanistan. And this is actually my drug bag here, my main drug bag, and I carried a little intubation kit and a lot of drugs and stuff in it. And, this is my bailout bag. This is my little survival bag. If we ever got attacked and we had to bail out and run, you know, you had like water and money and stuff. And then this is all my body armor here. So I don't know why. I just thought I'd throw a random picture in there just for the heck of it.
Contractor?
Yeah. Yeah, I was a contractor after I got out of the military for a little while. So. Huh?
How much you get paid? A lot of money.
I got paid pretty well. I was able to. I actually got injured, and I was able to pay to go to respiratory school out of pocket. But that was it. No more money. So, alrighty, guys, take a break.